When we talk about the female orgasm, it's often whispered about, joked about, misunderstood, or turned into a punchline. For something so central to human desire and intimacy, it carries a surprising amount of mystery, not just in bedrooms, but in science, medicine, culture, and the stories we tell each other. Tonight, I want to pull back the curtain on that mystery. I want to look at the biology, the history, the myths, and the lived experiences. I want to trace how culture shapes what we feel, and how in turn, what we feel reshapes culture. I grew up hearing two competing stories. One was a tidy, heteronormative version. Sex is for reproduction, climax is quick, and the male orgasm is the plot point. Any pleasure a woman gets is an afterthought. The other was hushed whispers, late-night conversations between friends, a mix of awkward laughter and confession. It's complicated, people would say. Sometimes it happens, sometimes it doesn't. You're probably doing it wrong. Those early fragmented narratives shaped my curiosity. I started asking questions. Why does one partner climax nearly every time while another rarely does? How much of this is anatomy? How much is culture, and how much is simply not yet understood? Let's begin with an image that helps. Imagine the body as a landscape. For centuries, maps of that landscape were sketched by people who never fully explored it. Scientific expeditions focused on treasure, others considered more valuable. Meanwhile, storytellers, lovers, and the people living inside those bodies developed their own local knowledge. Techniques, rhythms, cues. The female orgasm sits at the intersection of those maps, biological, psychological, social. To understand it, we need to go beyond cliches. The female orgasm is not one single thing with a single path. There are multiple kinds of stimulation, multiple timelines, and multiple ways that bodies respond. For many, it's genital, centered on the clitoris. For others, it can be internal, associated with the G-spot or pelvic sensations. It can be fast, slow, clenched, diffuse, even accompanied by tears, laughter, or a dreamy numbness. This range has always existed, but until recently, our scientific language struggled to describe it. Let's talk about the clitoris. For decades, medical texts either reduced it to a tiny nub or ignored it entirely. That omission had consequences. If the organ primarily responsible for female sexual pleasure is described inaccurately or omitted, then sexual health, education, and expectations become skewed. In the last 2 decades, high-resolution imaging and careful anatomical studies have redrawn that map. The clitoris is not a button. It's a complex organ with internal branches that extend around and under the pelvic bones. Its roots, bulbs, and a visible external glans mean it has a much larger presence than the old diagram suggested. Anatomy is the starting point, but biology alone doesn't tell the whole story. Hormones, neural wiring, and blood flow play their roles. Dopamine and oxytocin, the brain's reward and bonding chemicals, pulse through the experience. The autonomic nervous system, the interplay between sympathetic and parasympathetic responses, helps coordinate arousal and climax. For some, a surge of sympathetic activation leads to an orgasm. For others, too much sympathetic arousal blocks it. Small variations in hormone levels, health conditions, medications, or even stress can shift that balance. Now imagine 2 women. One has frequent orgasms, the other rarely does. One common explanation is anatomy. She has sensitivity in areas that mesh with typical stimulation patterns, but that's only part of the answer. The brain is the largest sexual organ. Attention, memory, emotional safety, and context shape sensation. If a person grew up ashamed of desire or learned that their pleasure is secondary, their body may tighten or dissociate in sexual situations. Anxiety, past trauma, or relationship dynamics can interfere with fully experiencing orgasm. Conversely, intimacy, trust, and focused attention can unlock responses that felt impossible before. I want to share a few stories I collected, not as scientific proof, but as windows into lived reality. A woman in her 60s told me she had never orgasmed during penetrative sex until her late 40s, when a longtime partner learned to center clitoral stimulation and slow down. She described it like discovering a hidden room in her house. Another woman, a new mother, spoke of how breastfeeding and sleep deprivation erased her libido. Months after recovery and after she and her partner communicated honestly about it, she rediscovered sexual pleasure by experimenting with timing and sensation. A queer woman described orgasm as radically different depending on whether her partner mirrored her rhythm and emotional tempo. These accounts underline a theme. The route to orgasm is often relational and experimental, not simply anatomical. Culture shapes expectation. In many societies, sex education emphasizes reproduction and disease prevention but gives scant attention to pleasure, especially female pleasure. That silence creates ignorance among partners, healthcare providers, and educators, and that ignorance becomes a barrier. Pop culture ramps up another set of pressures. Porn, movies, and mainstream narratives often depict female orgasm in stylized ways: quick, dramatic, loud, perfectly timed with male climax. Real life rarely matches that script. The mismatch produces shame. People feel abnormal, partners feel inadequate, and clinicians sometimes pathologize what might be normal variation. Science has tried to measure orgasm, but it's messy. Studies use different definitions, diverse methodologies, and small samples. Yet some patterns emerge. Surveys show a gender gap in orgasm frequency in mixed-gender partnered sex. Men report much higher rates of orgasm than women. This orgasm gap has sparked conversations about technique, communication, and fairness in the bedroom, but it also points to deeper structural issues: unequal attention to female pleasure, lack of education about anatomy, and cultural expectations around male performance. Medical conditions and medications also matter. Antidepressants, some blood pressure drugs, hormonal contraceptives, these can dampen libido or make orgasm harder. Conditions like vaginismus, pelvic floor dysfunction, endometriosis, and chronic pain disorders complicate sexual response. For people living with such conditions, orgasm is not just a question of technique. It's wrapped in medical management, therapy, and often advocacy. But let's return to the positive side. Learning, communication, and technique can shift outcomes. Sex therapists and sex educators often recommend 3 practical starting points: explore solo, communicate, and pace yourself. Solo sex. Masturbation is a laboratory where individuals learn what works for their bodies without the pressure of pleasing a partner. Communication, explicit, curious, and non-judgmental, allows partners to discover shared preferences. Pacing matters because arousal builds differently across people. Rushing or misreading signals often short-circuits the process. Technology has also changed the landscape. Sex toys, apps, and educational platforms provide new ways to learn and practice. Vibrators, for example, can deliver stimulation patterns that are difficult to replicate by hand or orally. Sex-positive platforms and creators are expanding the vocabulary around pleasure, normalizing diversity, and offering tutorials grounded in anatomy and consent. Historically, attitudes toward the female orgasm have swung wildly. In some cultures and eras, women's sexual pleasure was acknowledged and even celebrated. In others, it was suppressed or medicalized. In 19th century medicine, women's sexual problems were sometimes framed as hysteria, a catch-all diagnosis rooted in misogyny and ignorance. Treatments range from the benign to the bizarre. It's only in the last century that research started to pay real attention, and even then, progress was uneven. Scientific milestones matter. Masters and Johnson in the mid-20th century began systematic observation and laid foundational models of sexual response: excitement, plateau, orgasm, resolution. Their work helped normalize studying sex. Yet their models were often critiqued for being too linear and not capturing the variety of female experience. Later researchers proposed alternative frameworks, for instance, models that highlight desire as cyclical or that distinguish between spontaneous and responsive desire. These perspectives recognize that desire and orgasm are dynamic, influenced by context, relationship history, and individual psychology. There's also a political dimension. Feminist scholars and activists framed sexual autonomy as central to gender equality. They argued that understanding and respecting female pleasure was not a trivial matter but connected to bodily autonomy, reproductive rights, and broader social power. That activism pushed sex education, research funding, and cultural conversations forward. Let me pause on one controversial topic: the G-spot. First proposed in the mid-20th century, the G-spot was described as an erogenous zone on the anterior vaginal wall that could produce intense pleasure or even female ejaculation. The debate continues. Some studies find anatomical differences consistent with a sensitive area. Others find no distinct structure. Part of the confusion comes from the fact that stimulation in that region often indirectly stimulates internal parts of the clitoral complex or presses against the urethral sponge and surrounding nerve-rich tissue. In practice, some people report powerful orgasms from that stimulation, others feel nothing. The G-spot conversation shows how scientific debates and personal testimony can both be true, and why certainty is hard when human bodies vary so widely. Another subject worth addressing is orgasmic disorders. The diagnostic category includes persistent difficulty reaching orgasm despite adequate stimulation and desire. But labeling can help and harm. On one hand, it validates people's struggles and opens pathways to treatment. Pelvic floor therapy, medication adjustments, psychotherapy, sensate focus exercises, and couple-based interventions. On the other hand, pathologizing natural variation can create pressure and stigma. Clinicians now often adopt a biopsychosocial model that considers physical, psychological, relational, and cultural contributors. I want to be clear. Orgasm is not a moral imperative. Pleasure matters, but not at the cost of pressure or shame. Outside clinical contexts, insisting that everyone must orgasm every time creates unrealistic expectations and undermines sexual encounters. A healthier approach is curiosity, to notice what works, to communicate, and to respect that sometimes the goal of sex is connection, comfort, or shared intimacy rather than climax. Let's look at some evidence-based strategies that have helped people in clinical studies and in therapy. First, pelvic floor awareness and control. Tight or hypertonic pelvic muscles can block orgasm. Conversely, learning targeted relaxation and coordination can enhance response. Physical therapists who specialize in pelvic health use biofeedback, manual release, and exercises to retrain muscles. Second, cognitive behavioral approaches address performance anxiety and negative self-talk. Mindfulness and sensate focus, practices where partners focus on non-judgmental touch and present moment sensation, often reduce pressure and increase pleasure. Third, adjusting medication under medical supervision can restore libido and orgasmic ability when pharmaceuticals are the cause. Fourth, sexual technique, combining clitoral stimulation with penetration, varying pressure and rhythm, using longer, gentler buildups. Small experimental changes can yield big differences. In sex therapy, progress is rarely linear. A person or couple might try approaches that work, then face setbacks due to stress, illness, or life changes. Success is often incremental. A new type of touch, a conversation that reduces shame, the discovery of a rhythm that lands. Therapists emphasize curiosity, not performance. Treat sexual exploration like a shared experiment with no single right outcome. I also want to talk about diversity. Across orientations, ages, bodies, and abilities, orgasmic experience varies. Older adults may experience changes due to hormones or health, but many continue to enjoy satisfying sex. Trans and non-binary people face unique challenges as medical treatment, anatomy, and identity intersect. Disability scholars and activists highlight that people with disabilities deserve accessible sexual education and tools. Orgasm is not off-limits. Adaptations, communication, and creativity matter. Inclusive sexology tries to center those perspectives rather than treat them as afterthoughts. There's a cultural shift underway. Open conversations, sex-positive education, and better medical training are slowly changing how society talks about female pleasure. Apps, podcasts, and creators are normalizing topics once taboo. Clinics increasingly include sexual health as part of routine care. Still, gaps remain. Education systems in many places still omit pleasure. Medical curricula can lag in teaching sexual anatomy and communication skills. Bridging those gaps requires policy, training, and public conversation. Before we move to the clinical section, let's return briefly to the human stories because they resurface what statistics and anatomy can't capture: the feeling. One woman described an orgasm she hadn't expected, in the middle of ordinary life, after months of trying. She compared it to sunlight breaking through after a long winter. Another spoke of orgasms that arrive unexpectedly during a quiet walk, not even during sex. Sensations that are diffuse and deeply connected to emotional openness. These moments remind us that orgasm can be spiritual, mundane, tender, or ecstatic. There is no single narrative. Now we shift gears into a clinical and educational overview. I'll be clear, concise, and practical. Think of this as a primer: anatomy, physiology, common problems, and evidence-based interventions. Anatomy: the clitoris is the primary organ for female sexual pleasure. It includes an external glans, a visible shaft, an extensive internal crus, and bulbs that wrap around the vaginal canal. The vulva also includes the labia majora and minora, urethral opening, and vaginal opening. Internally, the vagina, cervix, uterus, and pelvic floor muscles contribute to sexual sensation. Nerve supply is complex. The pudendal nerve carries much somatic sensation. Autonomic fibers modulate blood flow and arousal. Understanding this architecture helps explain why external, internal, and combined stimulation can produce different sensations. Physiology of arousal and orgasm. Sexual arousal involves increased blood flow to genital tissues, lubrication, erection of erectile tissues, and increased heart rate. Neurochemically, nitric oxide mediates vascular changes. Dopamine supports motivation and reward. Oxytocin supports bonding and post-orgasmic feelings. The orgasmic phase typically involves rhythmic pelvic muscle contractions, subjective peaks of pleasure, and a sense of release. Women do not always experience a refractory period like men do. Many can have multiple orgasms in succession. However, individual variability in intensity and duration is huge. Common causes of orgasm difficulty. Psychological, anxiety, depression, history of sexual trauma, body image concerns, relationship conflict. Physiological, hormonal changes, menopause, postpartum, neurological conditions, pelvic surgery, chronic pain, poor pelvic floor coordination, pharmacological, SSRIs and other medications can delay or prevent orgasm. Lifestyle, alcohol and drug use, fatigue, stress. Educational, cultural. Lack of knowledge about body, porn influenced expectations. Lack of communication, assessment in clinical settings, good sexual history matters. Clinicians ask about frequency and context of orgasm, solo versus partnered sexual activity, arousal patterns, medication use, pain, and relationship factors. Physical exam focuses on pelvic health, signs of infection or hormonal changes, and pelvic floor tone. When indicated, referral to pelvic floor physical therapy, endocrinology, or mental health specialists is recommended. Evidence-based treatments, pelvic floor physical therapy, biofeedback, manual therapy, and exercises to correct hypertonic or hypotonic dysfunction, psychotherapy, cognitive behavioral therapy, CBT for sexual anxiety, trauma-focused therapy where relevant, and couple therapy for relational issues. Sensate focus exercises, structured graded touch exercises to rebuild intimacy and reduce performance pressure. Medication adjustments, working with prescribing clinicians to change SSRIs or switch to alternatives, or adding medication that can help sexual function. Device-assisted therapy. Vibrators and other devices can be prescribed or recommended as part of therapy to facilitate learning and neural retraining. Hormonal therapies. For menopausal sexual dysfunction, local estrogen or systemic hormone therapy might help, under medical supervision. Education and communication training. Explicit guidance on anatomy, positions, and techniques tailored to the person's body and preferences. Special topics. Orgasm after prostate or pelvic surgery in partners. Sexual function can change after surgeries. Couples may need to relearn sexual scripts and focus on alternative pathways to pleasure. Non-monogamous and kink communities, many find empowerment in varying scripts and explicit negotiation about desires. Consent and clear communication are essential. Aging. Menopause changes hormonal milieu, but many maintain satisfying sex lives. Lubricants, longer foreplay, and hormone therapy can help. LGBTQIA+ experiences, transmasculine and transfeminine people may have altered sexual response after hormones or surgery. Affirming care requires knowledge of those changes and tailored strategies. Research gaps and future directions. We still need larger, more representative studies, especially including marginalized groups, better neuroimaging that respects privacy, longitudinal studies on aging and orgasmic function, and trials comparing therapeutic approaches would move the field forward. Another frontier is integrating sex-positive education into medical training so clinicians can address sexual health routinely. Before closing, let's normalize a few practical tips anyone can experiment with. Start solo. Use a vibrator, your hand, or different touches to map sensation. Combine stimulation. Many people orgasm faster with direct clitoral stimulation plus other touch. Slow down. Longer buildup often produces more intense climax. Communicate specifically. Harder, softer, faster, slower, or pointing can replace awkward guessing. Practice pelvic relaxation. Deep breathing and awareness reduce tension. Consider professional help when pain, trauma, or persistent difficulties interfere with enjoyment. Finally, here's what matters most. The female orgasm is not a problem to be solved but an experience to be understood and respected. It sits at the intersection of body and mind, private desire and public conversation, biology and culture. It can be joyous, elusive, mundane, or transformative. The path to better sexual health runs through education, frank communication, clinical care when needed, and a cultural shift that places female pleasure on equal footing. If you take one thing from this conversation, let it be this: ask, explore, and be curious, with yourself and with your partner. Normalizing questions about pleasure, seeking accurate anatomical knowledge, and treating sexual difficulties with empathy and science will make more bedrooms and clinics spaces of learning, not shame. We've traced the landscape, the anatomy and neurobiology, the cultural stories, the clinical approaches, and the everyday practices that change lives. There is no single map that fits everyone, but there are tools to help each person chart their own route. Pleasure is not a reward for compliance, it's an aspect of health. Thank you for listening.